Very good evening, one and all, and warm welcome to the academic feast that is to follow. The ESC Congress was recently held, bringing forth several important new guidelines and clinical evidences. As we all know, the burden of cardiovascular disease in India is alarming, with Indians facing higher cardiovascular risk and often developing cardiovascular disease at a younger age compared to Western population. It is therefore vital to discuss these emerging insights to improve patient outcomes. Today, we are privileged to have esteemed faculty with us to share their expertise on the recent advances. It is my honor to welcome and introduce them. For the first talk on antiplatelet therapy in ACS or PCI, we have Dr. Andrew P. Ambrosi, sir, with us as an international speaker. Sir is research scientist and assistant professor at Kaiser Permanente, Northern California, local research chair and cardiovascular fellowship program director. Sir is national lead investigator for landmark global heart failure trials, including Moonraker, Iconic HF, and Detect HF study. Sir has published over 250 peer-reviewed manuscripts. So is editor-in-chief of Heart Failure Reviews and associate editor of for American Heart Journal and ESC Heart Failure. So is also recipient of major honors, including the 2024 Distinguished Mentoring Award and Top PI Award. We welcome sir. And for the second talk on newer evidences from ESC guidelines, we have with us renowned Professor Dr. Upendra Kaul, sir. Sir is Chairman and Dean at Batra Hospital, New Delhi, former Professor of Cardiology at AIIMS, PGIMER and GB Pant Hospital, a pioneer of coronary angioplasty in India, has trained over 400 cardiologists and authored 400 plus publications, including his memoir, When the Heart Speaks. Sir is founder director of Gauri Kaul Foundation, an NGO which establishes telecardiology units, heart centers, and mobile cardiac clinics in Jammu and Kashmir. Sir is past president of CSI and SARC Cardiac Society, founder member of Asia Pacific Society of Interventional Cardiology. Sir is also editor-in-chief of Asia Interventions, joint editor of Euro Intervention, and recipient of prestigious Padma Shri Award and Dr. B.C. Roy Award for contributions to cardiology. With this, we welcome both our faculties, esteemed doctors, and without further ado, I hand over the session to our first esteemed speaker, Dr. Andrew Ambrosi, sir. So over to you.
Great. Thank you so much, Dr. Prajapati. It's really an honor to be here today. Give me 1 second. I'm just going to go ahead and share my slides. Is everybody able to see my slides?
Yes, sir.
Outstanding. So thank you again for inviting me to speak today. I'm going to be reviewing antiplatelet therapy in ACS/PCI from guidelines to real-world clinical practice. And these are insights from studies that were presented at the recent ESC Congress in Madrid. It's a real tour de force of observational data. So really looking forward to presenting this, and happy to take any questions during the Q&A. So PCI, or percutaneous coronary intervention, has really transformed outcomes in both acute and chronic coronary syndrome. However, the success depends on optimal antiplatelet therapy, and really us as frontline providers were left to dealt with a challenging clinical dilemma. We need to prevent stent thrombosis while also minimizing bleeding risk. And that's really the yin and the yang in interventional cardiology and PCI. It's finding the optimal balance that's key to successful PCI outcomes. So I'm going to go through 3 topics today related to that. So number 1, timing and pretreatment. Does early antiplatelet initiation before PCI improve stent safety? Number 2, the duration of therapy. Can we safely shorten or de-escalate dual antiplatelet therapy without compromising ischemic protection? In number 3, I'm going to discuss the choice of P2Y12 inhibitor following DAPT. So how do ticagrelor and clopidogrel compare across diverse high-risk patient populations? And I'll review, 3 different clinical scenarios: those that are on DOACs in cardiogenic shock, as well as chronic coronary disease. So several key themes are going to emerge during my talk today. Number 1, the antiplatelet strategy and stent safety. Number 2, the duration of dual antiplatelet therapy, comparing longer versus shorter. And then again, as I just alluded to, number 3, looking at different P2Y12 inhibitors, so specifically ticagrelor and clopidogrel in several target populations. So first, I'm going to talk about antiplatelet strategy and stent safety. So the impact of antiplatelet pretreatment on stent thrombosis in patients undergoing PCI in real-world practice. Insights from the France PCI registry. So this first study addresses a key problem. So there's not a really established evidence on whether we should do pretreatment with P2Y12 inhibitors before PCI in chronic coronary syndrome or NSTEMI. On the one hand, there's no clear benefit here on major adverse cardiovascular events, and there's also the potential increase in the risk of bleeding complications. So the France PCI registry attempted to address this. So it's real-world insights into contemporary PCI practice. So the patient population included both patients with chronic coronary syndrome and NSTEMI, and the comparative outcome here was looking at the comparative effectiveness of with or without dual antiplatelet pretreatment. And the goal here being to bridge the gap between guideline recommendations and contemporary clinical practice. So again, this was a French registry of PCI, 86 centers from 2014 to 2025, more than 44,000 unique individuals undergoing approximately 54,000 PCI procedures, and patients were divided into 2 groups: pretreatment with a P2Y12 given before PCI, or no pretreatment. And the breakdown was roughly 80 versus 20%. Baseline characteristics are what you would imagine for this patient population: average age around 70, predominantly male, high prevalence of diabetes, hypertension. Of note, radial access was quite high here, which is typical in Europe. Usually a radial first approach, but higher than many other areas in the world, including the United States. And a fair number of patients underwent ad hoc PCI in this registry, about 60% in the pretreatment versus 86% in no pretreatment. Jumping right to the outcome of interest here. So the main outcome we were looking at in this study was in-hospital definite stent thrombosis, defined per the ARC criteria. And it was found that in the pretreatment group, it was significantly lower. The rate was about 0.1% compared to 0.4% in the group not receiving pretreatment. And the odds ratio did favor pretreatment here, with an odds ratio of 0.335. And you can see how this shakes out in the graph on the right here. And this does seem real because, as you would expect, the rate of in-stent thrombosis, although low overall, was highest, immediately after the procedure. Also of note here, there was no increase in major bleeding events in the pretreatment group. In fact, if anything, major bleeding appeared to be slightly less, 2.5% versus 3.4%. Also looked at 1-year clinical outcomes, major adverse cardiovascular events, all-cause mortality, as well as stent thrombosis. And you can see the events here. In summary, overall pretreatment was associated with lower MACE, all-cause mortality, and cardiovascular mortality, while stent thrombosis rates as we approached 1 year was not significantly different. The author group also took a look at the independent predictors of stent thrombosis, including not only P2Y12 pretreatment, but also some patient factors and some procedural-related factors. And the 3 major things that shook out were the things that you would imagine. Lack of P2Y12 pretreatment was associated with higher rates of stent thrombosis, longer stent, as well as smaller stent size. So I think that this, gives some face validity to these results. So key implications here in this In this large contemporary cohort with high rates of radial access and ad hoc PCI, it really challenges current guideline reluctance on routine pretreatment in chronic coronary syndrome and NSTEMI patients undergoing PCI. And as the authors conclude, P2Y12 inhibitor pretreatment was associated with a significant reduction in early in-hospital definite stent thrombosis without an increase in major bleeding. So pretreatment, I think, is something that could be considered in select patients who are considered to be low bleeding risk. All right, going to shift gears a little bit and talk about the second topic. So the duration of DAPT after PCI. So I'm going to go over several studies here. So first, going to compare 12 versus 1 month DAPT, comparative outcomes after aspirin cessation with the HT Supreme stent. So key question here is, can shorter duration of DAPT 1 month provide comparable ischemic protection to longer DAPT 6 to 12 months while reducing bleeding risk? And the evidence source here is going to be a pooled analysis of 2 trials with this stent, the Pioneer 3 and the Pioneer 4 RCT. Both of them evaluated outcomes after PCI with the healing targeted HT Supreme drug-eluting stent. So a little bit more about these 2 trials. They had similar eligibility criteria. So patients had to be adults, had to have coronary syndromes, and key exclusion criteria were left main disease, low EF, severe renal impairment, bleeding diathesis, or chronic anticoagulation. And these trials compared 1 month, so short DAPT versus longer, 6 to 12 month DAPT after PCI. So looking at some of the outcomes here, the main efficacy outcome was looking at showing that there were comparable MACE rates with short DAPT versus longer DAPT without an increased risk in ischemic events after aspirin cessation. So relatively similar efficacy outcomes with shorter versus longer duration DAPT. Also looked at bleeding events and found that bleeding events were not statistically different between the short and the long DAPT groups, although the bleeding does, remain an area of concern. The longer we treat patients with DAPT, we're obviously concerned that that's going to lead to an increased risk of bleeding, but was not seen here. Some of the predictors in stent features, some of the independent predictors of adverse events at 1 year, patient factors that one might expect, so smoking, older age, diabetes, and just want to highlight a couple of features of this stent, that may have supported shorter DAPT. So this, for those of you that are not familiar with it, it's a sirolimus releasing, rapid within 28 days, leads to peak tissue concentration. And the thought here is this leads to early endothelial healing by about 60 days, and this may potentially facilitate the shorter duration of DAPT here. So key implication from this study, so PCI with the HT Supreme stent in 1 month DAPT demonstrated comparable MACE and bleeding outcomes to longer DAPT without a rebound in thrombotic events after aspirin cessation. Going to transition to another study here. So a shorter duration of DAPT for PCI following acute coronary syndrome. And this is a meta-analysis of randomized clinical trials. So the key question here again is international guidelines recommend 12 months of DAPT after PCI and ACS, but many recent RCTs with shorter DAPT durations challenge this. So can small DAPT strategies, shorter DAPT strategies of 1 to 3 months provide comparable ischemic protection while reducing bleeding risk? So this is a meta-analysis pooled of 9 RCTs involving about 30,000 ACS patients to compare short duration DAPT with traditional DAPT of 12 months or longer. And after the short duration DAPT period, patients were continued either on P2Y12 or aspirin monotherapy. So here you can see the main outcome of interest, bleeding. It was significantly reduced with short DAPT. So a relative risk ratio of 0.52, which was statistically significant when the results were pooled across all the trials. So not a major surprise here. Shorter duration of DAPT, one would expect less bleeding risk. But what's interesting is looking here at stent thrombosis. So again, this is a rare event, relatively speaking. So it's hard to it's harder to study, which is why we do this pooled analysis across many randomized clinical trials. Although there was a trend towards increased risk with shorter DAPT, it approached but did not reach the threshold for statistical significance. So safety seemed to be relatively similar between these two groups. So in conclusion, short DAPT is a safe alternative to traditional 12-month DAPT for many ACS patients after PCI in terms of major ischemic outcomes. The main advantage, as one would imagine, is lower bleeding risk. However, clinicians must consider that a possible but statistically non-significant increase in late stent thrombosis with shorter DAPT. Final therapy duration really should be probably tailored to the patient, kind of weighing their bleeding and ischemic risk profiles, whether a patient's at relatively higher of one versus the other. So going to transition to the final topic here and talk a little bit about dual antiplatelet therapy de-escalation, followed by either aspirin or P2Y12 monotherapy for patients with PCI after acute coronary syndrome. So this is another systematic review and meta-analysis. So in ACS patients post-PCI after short DAPT, which monotherapy provides the best net clinical benefit? Is it aspirin or a P2Y12 inhibitor? So key outcome in this study was looking at NACE and did find that P2Y12 monotherapy reduced NACE and bleeding events compared to aspirin monotherapy. And specifically, it seemed that the P2Y12 monotherapy reduced any bleeding or major bleeding, and the benefit of P2Y12 monotherapy seemed to be more pronounced with ticagrelor compared to clopidogrel. So in patients undergoing PCI, shorter DAPT significantly reduces bleeding events, including major bleeding events, without increased ischemic harm. However, the outcomes do vary depending on subsequent monotherapy, and it seems that P2Y12 inhibitor monotherapy significantly reduced NACE and bleeding and major bleeding, while the benefits achieved by aspirin monotherapy are largely offset by ischemic events. So the benefits of P2Y12 inhibitor monotherapy were also largely driven by ticagrelor rather than clopidogrel in this case. So now let's dive into the details and look a little bit about the choice of P2Y12 monotherapy. So ticagrelor versus clopidogrel in comparisons in specific populations. So ticagrelor versus clopidogrel in patients with acute coronary syndrome undergoing percutaneous coronary intervention using direct oral anticoagulants. So this is a clinical scenario that's very common that we all deal with as practitioners. A lot of patients with both coronary disease and atrial fibrillation, so having an indication for dual antiplatelet therapy as well as direct oral anticoagulants. So the key question here is ACS patients undergoing PCI plus DOAC. Guidelines recommend dual therapy, a P2Y12 plus a DOAC, no aspirin. But what is the choice of P2Y12 inhibitor in this setting? So these are some data from the Swedish Coronary Angiography and Angioplasty Registry, SCAR, looking at patients treated with ticagrelor versus clopidogrel. So on the bottom of my slide, you can see the baseline characteristics varied a little bit. As you would imagine, patients receiving ticagrelor were a little bit younger, similar in terms of sex, more likely to be diabetic and to come in with acute and a STEMI presentation. But when we looked at the efficacy outcome here, there was really no significant difference between ticagrelor and clopidogrel in major adverse cardiovascular events, all-cause mortality, MI, stroke, or stent thrombosis. So in conclusion, but in contrast to that, when safety events were looked at, there was a higher rate in the ticagrelor group compared to clopidogrel, so 4.9% versus 3.7%. And these results were statistically significant with a hazard ratio of 1.51. So key implication here in ACS patients on DOACs undergoing PCI, it does appear that ticagrelor was associated with a higher bleeding risk compared to clopidogrel, with no difference in MACE, mortality, or reinfarction. So there is a slight safety signal here. So in patients with a history of AFib receiving a DOAC, in that specific scenario, we may favor a less potent P2Y12 inhibitor like clopidogrel. So a second study is looking at the efficacy and safety of ticagrelor versus clopidogrel in acute myocardial infarction associated cardiogenic shock. So this is a propensity score matched analysis. So study design here, this is a smaller study, so a single center retrospective analysis. It's just a single center in Portugal. They looked at patients from 2016 to 2024. They initially included about 151 patients with AMI-related cardiogenic shock, but after developing a propensity score match cohort where they try to match patients on as many baseline characteristics as possible, they were left with about 88 patients, so 44 patients receiving ticagrelor versus 44 patients receiving clopidogrel. And here you can see the main outcomes. So 30-day mortality was significantly lower in the ticagrelor group, 34.1% versus 54.6%, which was statistically significant. And you can see the Kaplan-Meier curve there. And the MACE rates were also lower in the ticagrelor group. Major bleeding, however, were similar between both groups. So 63.6% in ticagrelor versus 59.1% in clopidogrel. So although it was nominally higher in the ticagrelor group, it was not a statistically significant difference. Other complications such as stroke, reinfarction, embolic events didn't differ significantly between groups. So in patients with acute myocardial infarction, cardiogenic shock on DAPT, it did appear that ticagrelor was associated with significantly lower 30-day mortality and MACE rates compared to clopidogrel, with no significant increase in major bleeding risk. So the final population we're going to look at, so we're going to, this study evaluated the safety and efficacy of ticagrelor versus clopidogrel following PCI and chronic coronary syndrome, so a more stable population than we just reviewed. So this is a prospective cohort study of 300 patients, 150 each receiving ticagrelor versus clopidogrel at a Kuwait teaching hospital from July 2023 to June 2024. Patients were assigned to drugs based on the physician's judgment rather than randomization. So this is just an observational study. So there is, the possibility of bias by indication. Researchers measured the rates of stent thrombosis, revascularization, bleeding, and dyspnea as primary and secondary outcomes. So this slide shows the key outcomes. So stent thrombosis occurred less often in the patients receiving ticagrelor, 5 versus 13.3%. This was a statistically significant difference in representing a 62.4% relative risk reduction. Revascularization was lower in the ticagrelor group as well, subsequent revascularization, but this was not statistically significant. And then, as you might imagine, given that ticagrelor is a more potent P2Y12 inhibitor, the risk of major bleeding was higher, 10% versus 6%, but this did not appear to be did not appear to be statistically significant. There were only about 300 patients in the study, so this may have been an underpowered observation. And then again, as you might imagine, with ticagrelor, which has been associated with adenosine release and dyspnea, dyspnea was more common in this group, so 8% versus 3.3%, and this is a well-known side effect of the drug. So in PCI patients, ticagrelor offers a significant reduction in MACE compared to clopidogrel, particularly in preventing stent thrombosis. However, this benefit does come with an increased risk of adverse events such as major bleeding and dyspnea, necessitating careful patient selection. Personalized treatment strategies are critical to balance efficacy and safety, especially in populations with comorbid conditions like diabetes and hypertension. And while ticagrelor demonstrates strong efficacy for high-risk patients, clopidogrel remains a viable option for those with heightened bleeding risk or respiratory risk. So thank you so much for listening to my talk this morning. It was really a tour de force of data from ESC, but hopefully we gained some good insights about several emerging areas. Pre-treatment with P2Y12 inhibitors, short versus longer duration DAPT, as well as choice of P2Y12 monotherapy following DAPT. So at this point, I'm going to go ahead and turn it over to our second speaker, but I will review the chat, and I welcome any questions during the Q&A session. Thank you so much.
Thank you, Dr. Amro.
Well, thank you very much, Andrew. It was very interesting listening to you. Very important topic, and I think very educating. Thank you. So, should we start, or
Yes, sir. So we can start with your session.
Dr. Prajapati? You're on mute. Yeah.
Yes, sir. Yes, sir. We can start with your session, sir.
Hello, yes, sir. We can start with your session.
Just a minute. What happened? Where is my slide? Just a minute. So, is it visible?
Yes, sir. Perfect, sir.
So, now we're going to discuss something very important regarding lipids and stress, and also something regarding the pregnancy and maternal heart disease, how to handle it better, fit, and high standards. These are the focused areas for this evening's meeting. Number one, the 2025 focused update on dyslipidemia. We'll follow it up with consensus statement on the mental health and cardiovascular disease. And finally, the ESC guideline on cardiovascular disease and pregnancy. And these are the key updates from the ESC 2025. Let us start with the guidelines for the management of dyslipidemias. Number one, the key updates are the updated risk algorithm. The new SCORE 2 and SCORE 2 OP tool has been introduced to estimate 10-year risk for both fatal and non-fatal cardiovascular events. And it's very simple. You just have to log on and go to SCORE 2 OP, and you will get a questionnaire, and you just have to go on clicking it, and finally it will tell you what is your 10-year risk of getting a coronary event, whether it is fatal or non-fatal. Then we'll also talk about role of imaging to emphasize the risk assessment, especially in detecting atherosclerosis with calcium scores in asymptomatic patients who are at moderate risk. And then lipoprotein little a, which has become very important topic these days, because we're going to get some drugs which are in the pipeline, which are going to be useful in these patients who have high lipoprotein little a. And a threshold of 50 milligrams per deciliter is now recognized, above which it should be considered a cardiovascular risk enhancing factor. And I'd like to add here that South Asians have got, in general, much higher lipoprotein little a levels than the Caucasians. And that may be one of the reasons that we get cardiovascular events a decade before, what people in the West get. The new therapeutic options, bempedoic acid, which we have been using for 3 or 4 years now, has been endorsed now for both the primary and secondary prevention, especially in patients who cannot use statins because of intolerance or some other contraindications. And then we also have an intravenous PCSK9 inhibitor, which is recommended for homozygous familial hypercholesterolemia. I think it is much more potent and longer lasting as compared to evolocumab. And then hypertriglyceridemia, which again is a big problem in South Asian countries. But when it is very severe, it is linked to familial hyperchylomicronemia syndrome, which can lead to very serious problems like pancreatitis. And this particular drug, the volanesorone, which is marketed as Wilivra in Europe, can be used for that. Treatment goals for low density lipoprotein cholesterol across the various risk situations for total cardiovascular risk. The current LDL cholesterol remained unchanged for high risk individuals, but LDL cholesterol less than 40 may be considered in extreme risk patients, those with recurrent events despite maximal therapy or with polyvascular disease. And this kind of a problem that is extremely high risk patients are commonly, not commonly, but seen often in our milieu. Recurrent cardiac events, young age, multiple risk factors, hyperlipidemia, chronic renal disease associated, they all are very high risk patients. And then in patients with recurrent ischemic stroke, there is a little change that despite achieving LDL cholesterol less than 55, possibly lowering it further is not going to be so useful. So the focus should shift from only increasing the statin dosage or other lipid-lowering agents to reduction of other uncontrolled risk factors like hypertension, like diabetes, like atrial fibrillation, which are recurrent important causes of ischemic strokes. Now, the revised thresholds from the score 2 and score 2 OP. Score 2 is in relatively younger people, less than 70 years of age, and score 2 OP, older people, is more than 70 years of age. If it is risk shows it's more than 20% risk in getting event in next 10 years, it's very high risk. If the risk is between 10 to 20%, it is called high risk. If it is between 2% to less than 10%, it's called moderate risk. And if it is very low, that is low risk, is less than 2%. So the patients have been classified as moderate risk by score 2 or score 2 OP, considering coronary artery calcium score derived from non-contrast CT scan or carotid or femoral plaque detection, like by carotid intimal medial hyperplasia, and which can be done by the vascular ultrasound, keeping under the neck, looking at the carotid artery and its intima media. And this can refine the risk classification. If that is there, if the calcium score is high, or if there's a increased intimal medial ratio, then you can go up one category. So score 2 is recommended in apparently healthy people, as I already told you, in less than 70 years without established atherosclerotic cardiovascular disease, diabetes, chronic kidney disease, or genetic disorders for estimation of 10-year fatal and non-fatal cardiovascular disease. And this is class 1 indication. Score 2 OP, that is for apparently healthy people more than 70 years without established atherosclerotic cardiovascular disease, diabetes, chronic kidney disease, or genetic disorders, where the estimation of 10-year fatal and non-fatal cardiovascular risk is high. Presence of subclinical coronary atherosclerosis by imaging, if you find it by calcium score, should be considered as a risk modifier in individuals at moderate risk or around treatment thresholds. And it's a class 2A indication. That means most people agree on it. Other risk modifiers like lipoprotein(a), family history, should be considered in individuals at moderate risk or around treatment thresholds like class 2A, level of evidence B. And finally, the HDL cholesterol, that is high density lipoprotein, is no longer considered a protective factor and is no longer concluded as a cardiovascular risk factor or a risk factor modifier, because we've seen that agents increasing HDL cholesterol have really not worked in reducing the event. And this we're talking about primary prevention. Now, lipoprotein little a levels above 50 milligrams should be considered in all adults as a cardiovascular risk enhancing factor, with higher lipoprotein A levels associated with a greater increase in risk. That also means that once in a lifetime, LP little a levels should be estimated so that you know if it is high, you know you are at a person with a higher risk, and then you should be very careful about the other risk factors. Now, the risk modifiers based upon the score 2 and score 2 OP algorithms. These are the demographic clinical conditions. If you have a family history of premature cardiovascular disease in men less than 55, women less than 60 years, if you have a South Asian ethnicity, as I told you, that South Asians are more prone, stress symptoms and psychosocial stressors, social deprivation, obesity, which is again growing, increasing number of people in our population is becoming, getting obese. Physical inactivity, which is one of the reasons for getting obese, is a risk factor. Chronic immune-mediated inflammatory disorders, which again, atherosclerosis is an inflammatory disorder. So persons with a chronic immune-mediated inflammatory disorders like rheumatoid arthritis or problems like that is also one of the clinical conditions. Major psychiatric disorders, history of premature menopause, preeclampsia or other hypertensive disorders of pregnancy, and HIV infection. They're all, clinical conditions or demographics which you should be knowing that these can be clinical condition. And the biomarkers like if a elevated HSCRP, if the HSCRP is persistently more than 2 milligrams per liter, is a risk factor. They're more prone to get problems. In fact, some people like Paul Ridker and others have advised that independent of lipid levels, HSCRP more than 2 may, be very, should be given lipid-lowering agents in moderate to high doses. And then elevated lipoprotein little a, if it is more than 50, we already talked about this again as an important risk factor as a biomarker. So these clinical factors, which we already discussed, and the biomarkers can reclassify patients into a higher risk category than their score 2 score suggests, directly influencing our decision on LDL cholesterol goals and the intensity of treatment. Now, this is the lifestyle interventions. Lifestyle interventions have been always very important, and in the 2025 ESC guideline, they have again been reimposed. Now, these red squares mean that they're very high risk patients, and all of them should have lifestyle modification. In fact, whether the total cardiovascular is low, moderate, high, very high, or you know, for primary prevention, or very high in those who already have had an event, that means secondary prevention, it is a very important component. And in those marked with red, it has to be combined with concomitant drug interventions. Whereas if it is very high in this situation, if your LDL cholesterol is less than 55 or less than 70, possibly lifestyle modification is a kind of a gray zone, borderline. Similarly, if it is less than 100 in high risk patient, once again, it is a kind of borderline. Whereas in low, moderate, and high, lifestyle advice is meant for all. But if lifestyle in low risk, if the LDL cholesterol is very high, that means if it is more than 116, then obviously you have to consider drug to be added. Likewise, in moderate also, you have to consider adding a drug, which again is a indication which is not red, but one should consider it. Not moving, let me. What happened? Okay, coming to pharmacotherapy for lowering LDL cholesterol levels, and let us see what the guidelines say. Well, LDL cholesterol lowering therapy should be considered in persons who are at very high risk, and the LDL cholesterol should be between 55 and 70. At high risk and LDL cholesterol, if it is between 70 and 100, we should consider further LDL cholesterol reduction. In moderate risk and the LDL cholesterol is between 100 to 190, one should consider enhancing the therapy. At low risk and LDL, and if it is at low risk and LDL cholesterol between 116 and 190, once again, lipid-lowering therapy should be considered. Coming to non-statin therapies. Non-statin therapies with proven cardiovascular benefit are used or should be used if the patient is unable to take statin therapy, meaning thereby that statins are always the drugs of choice, but there are 5 to 10% of people who may not be able to take it. In that situation, non-statin therapies should be given, and bempedoic acid is one of them. People who are unable to take statin therapy, bempedoic acid plus statin with or without ezetimibe could be given in high-risk patients to achieve LDL cholesterol, because this combination is going to reduce the LDL cholesterol further, as we'll be seeing in a minute. And intravenous evinacumab is a new agent for homozygous familial hyperlipidemias, where one has to start therapy very early because the LDL cholesterols are very high, something like 400, 500, and you're not going to get much benefit by oral drugs, although you give them. And then you have to give this agent, and that reduces the LDL cholesterol significantly. So in the patients who have coming with acute coronary syndrome, intensification of lipid-lowering therapy during the ACS hospitalization. If the patients who were on any lipid-lowering therapy before admission, obviously you have to intensify it and initiate combination therapy with high-intensity statin plus ezetimibe during index hospitalization. If the patient is considered in treatment naive ACS, that means the patient has come with an acute coronary syndrome and has not been on therapy, then you can start them on high intensity statins and adjuvants, because one knows how much LDL cholesterol reduction is going to come with statins. Keeping that in mind, we should, start them on multiple drugs. Patients who have hypertriglyceridemia, in that situation, high dose icosapentaenoic acid in a very high dosage is considered along with the statins to reduce the elevated triglyceride levels. And once again, this for severe hypertriglyceridemia, as I told you, that around 300 milligrams per week is a new drug which is shown to reduce the triglyceride levels and ultimately reduce the pancreatitis risk. Now, this is important to learn that recommendation for LDL cholesterol reduction. Moderate intensity statin, that means if you're using rosuvastatin, 20 milligrams, it will reduce LDL cholesterol by 30%, or 40 milligrams of atorvastatin. But if you're using high intensity statins, like 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin, we expect LDL cholesterol reduction to up to 50%. Ezetimibe alone is a weak drug and it just reduces LDL cholesterol by about 20%. Likewise, bempedoic acid used alone reduces it by 23%. But if you combine bempedoic acid and ezetimibe, LDL cholesterol reduction can go further to 38%. High intensity statins plus ezetimibe, 60% reduction. High intensity statin plus bempedoic acid, almost same, around 58%. High intensity statins plus ezetimibe and bempedoic acid goes to about 68%. And if you use PCSK9, inhibitors, in that very strong agents, they reduce the LDL cholesterol by about 60%. But if you combine this monoclonal antibody to PCSK9 and add ezetimibe, it further reduces the LDL cholesterol by about 70%. And if you add ezetimibe and bempedoic acid to PCSK9 inhibitors, then 75% reduction. Similarly, if you have high intensity statins and PCSK9, it will go to as low as 80%. And if you combine everything, high intensity statins, ezetimibe, bempedoic acid, and PCSK9, inhibitors, then you can see that up to 86%. So you now know, according to these ranges, what combination is going to reduce the LDL cholesterol to approximately what percentage. So one should start with that, depending upon what is your aim, especially in patients with acute coronary syndrome, where you want to reduce the LDL cholesterol quickly. There's no point of starting with a low dose statin and then go on increasing. So you start away with high dose and combinations if the risk is very high. So from lipidemias, we now come to another very important aspect, which was, had discussed at the this year's ESC. That's the clinical consensus statement on mental health and cardiovascular disease. Now we know that mental health and cardiovascular disease, they have got a symbiotic relationship. The mental health conditions like depression, anxiety, anger, and other things invite cardiovascular diseases. So they increase this cardiovascular risk, they increase the risk. And if you increase awareness in education, then increase in the research, increase screening, and that leads to having a situation by which you can help the patient. So implementation and testing of consensus-based guidelines. This can be active principle, psychocardiac teams, and stepped care approach. All that improves the management and better outcomes. Now, consensus statements which were given there, that cardiovascular care should be patient-centered, addressing both the physical as well as the mental health, because mental health is extremely important. So a multidisciplinary psychocardio team, which includes mental health professionals, is essential for the assessment, support, and management of patients and caregivers. Cardiovascular services should adopt the psychocardio model to local contexts, resources, and population needs. This is a subject which is, very important and not recognized so clearly by at least in our population of doctors. So cardiovascular risk associated with mental health in individuals who do not have cardiovascular disease. So if you recognize it and start it, you're going to have some important effects on preventing cardiovascular disease. Now, like examples of psychosocial stress, various kinds of stresses, work stress, impaired social relations, socioeconomic stress, loneliness or social isolation, they all lead to various consequences like hypertension, coronary disease, cerebrovascular disease, peripheral vascular disease, atrial fibrillation, lead to higher chance of ventricular arrhythmias and myocardial infarction, sudden cardiac death, and heart failure. So that's the importance of these psychosocial stresses. And the potential interventions which are required, you start from the individual level, you can go to the community level, or make a policy by the health providers. So the consensus statements for management of psychosocial stress and promotion of mental well-being are essential components of integrated cardiovascular prevention, risk prevention. Screening for depression, anxiety, and some of these PTSD is advised to integrate it into the cardiovascular risk assessment. Mental health and mental health conditions in patients with cardiovascular disease, if the patient already has cardiovascular disease. Now, these are the situations. Patients after post-myocardial infarction, according to a lot of data, 1/3 of them have depression, and about 12 to 64% patients can have anxiety, which is, which is high at 3 months. Depression is higher in women. Patients who have advanced heart failure or are post-transplant patients, they have a depression of 25 to 35% and anxiety of around 11% with hypertension. Patients who are on implantable cardioverter defibrillators, they have depression in 15 to 20% and 11% new onset at 2 year. Anxiety levels of 20 to 36% and 15% for the new onset ones. And similarly, you have depression in pulmonary hypertension. These patients who have pulmonary hypertension very often idiopathic. 28% have depression, and it ranges from as low as 9 to as high as 70%. And about 1/3 have anxiety, and a range between 9 to 58%. Patients with chronic heart failure, up to 22% have got depression, and that can be up to 42% in very sick NYHA class 4 patients. And they're really very anxious. Up to 3/4 can have associated coexisting anxiety. Atrial fibrillation, a common arrhythmia seen in patients for people more than 65, 70 years of age, have depression in about 1/3 of patients, anxiety in once again in about 1/3 of patients. And persons with adult congenital heart disease once again have 24% of them can have depression, which is more than in general population, which is about 15%. Similarly, anxiety is also there in these adult congenital heart disease patients in up to 13%. So that is the importance of studying the mental health, depression, anxiety, hostility, all these things. So once you have identified these prevention and management of mental health issues, then what you have to do? Screen them during the clinical encounters, start with 2-item questionnaires, consult psychocardio teams for patient referral and support, and consider patient or the healthcare provider. If the first check, you have checklists for that, and you have a formal screening of this, like general anxiety disorder 7, or what's called as the PHQ-9, that is patient held questionnaires with validated tools. So these should be discussed. Results in care should be planned with the patient and family caregiver. One should consult the psychocardio team for patient referral and support, and consider patient and caregiver preferences. So multidisciplinary psychocardio team is very important. One should know when to consider, how to do it, and who should be considered. So following the new cardiovascular disease diagnostic events, periodically it should be done, and when it is clinically indicated, it should be done. So one has to be aware of these things. So the consensus statement on screening, if one has to sum up, screening of mental health with validated screening tools is advised after a new diagnosis or cardiovascular event at least once during follow-up and any time based on clinical judgment of need. Initial simple screening with the 2-item measures, that is Woolley questions, PHQ-2 or GAD-2, can be incorporated into routine practice. And if you find an abnormal result in the initial screening, a longer validated screening instrument should be used to find out if the conditions of the anxiety and the stress is low, moderate, or high. And especially if it is moderate and high, one has to, become aware of it and use measures which could be, counseling or drugs. So what is the step care model? All cardiovascular disease patients should be screened for this. Patients with positive initial screening should be identified, and patients with severe mental illnesses should be screened because they have more chance of getting cardiovascular problems. Lifestyle measures and psychoeducation, mental health assessment by the PHQ-2 and GAD, these are, those apps. Referral for diagnostic assessment and optimal treatment, and pharmacological and non-pharmacological treatment is required by them. Primary care or cardiovascular care team, and once a new diagnosis or event has been made, it has to be done periodically at time of detection as per the clinical need. So stepped care model for assessment and management of mental health condition in people with cardiovascular disease is very important, and this has been emphasized at the ESC 2025. Now, what is the algorithm? How do we do it? People with depression, anxiety, or post-traumatic stress disorders should be screened. And if the patient is in remission or with mild symptoms, or if the patient is already on psychotherapeutic therapy, offer psychological support. If the patient has moderate or severe according to the criteria, then psychiatric consultation should be sought. And then one has to have new psychotropic antidepressant medications, clinically based choice, depending on severity of the psychiatric symptoms, what drug you are giving, because high doses of these drugs can, in patients who already have cardiovascular disease, can produce some problems. So one has to be very careful regarding the side effects, lifetime cardiovascular disease risk, comorbidities, and patient's preferences, so that if you select a patient, he has to be guided, and then it is to be usually a long-term therapy. Special constitutions like these drugs of belonging to SSRIs, that is, serotonin receptor inhibitors, and then SNRIs, which are once again serotonin and norepinephrine receptor inhibitors or newer antidepressant. There are a number of them available for up to 4 weeks, and then gradual discontinuation of benzodiazepines, which are frequently used by these patients, is recommended. And avoid antidepressants in heart failure, except in severe depression, where risk of untreated depression outweighs the heart failure risk. So assess and manage cardiovascular disease risk factors, including medication if needed. So then the consensus management statement is that antidepressant use should be encouraged in patients with moderate to severe anxiety disorders and depression. Antidepressants in heart failure, severe depression symptoms, where the risk of untreated depression outweighs the risk of taking antidepressants. And switch to newer antidepressants with better safety profiles, because many of them are on older agents, which can lead to some unwanted effects on the heart, like patients with ventricular arrhythmias, where drugs, if they prolong the QT interval in the ECG, should be avoided, and possibly, escitalopram and very, commonly used drug in high dose should be avoided. So therapeutic drug monitoring should be done. It's advisable to optimize the pharmacotherapy and minimize the potential side effects. So the clinically relevant drug interactions can happen because these patients have multiple drugs, and drug-drug interactions can lead to problems. So that all should be done. And for that, a team consisting of a cardiovascular specialist and a psychiatric specialist and sometimes a neurophysician, they all should be working together. And finally, we come to the management of cardiovascular disease and pregnancy. These are the key updates. Risk stratification with refined, modified WHO classification for more nuanced risk assessment and counseling. Pregnancy heart team, formalized as the central coordinating entity for women with the modified WHO class more than 2, ensuring seamless care across all the stages. Pregnancy heart team integration, establishment of dedicated pregnancy heart teams to optimize maternal fetal outcomes using the evidence-based use of antihypertensive, the drugs which are safe during pregnancy. Lipid-lowering agents, most of them are unsafe, so one has to be very careful. And therapies for cardiogenic disorders if they have, while providing guidance on delivery mode. And then patients, transplant and advanced disease. Pregnancy should be postponed for more than 12 months, and post-heart transplant young females with timing and management individualized across to the graft function, because they're on immunosuppressive therapies, and that can lead to problems during pregnancies. So the overall cardiovascular risk has to be emphasized. The key recommendation is, first of all, an immediate assessment, an immediate formal diagnostic assessment for suspected, deep vein thrombosis is recommended, ventricular, thromboembolism, should not be postponed. Immediate treatment, empirical treatment initiation of therapeutic dose of low molecular weight heparin should be considered in patients with thromboembolism, vascular thromboembolism, if there's a strong clinical suspicion. And then you come to the treatment and team care. Anticoagulants, therapeutic dose of low molecular weight heparin is recommended. Multidisciplinary involvement in the pregnancy heart team, including a vascular specialist and a hematologist, is recommended. And finally, high risk pulmonary thromboembolism, reperfusion therapy may be required. Catheter-based strategy or systemic thrombolysis should be considered for acute high-risk pulmonary embolism. These are, some specialized procedures done by a well-trained team in a cardiovascular department. So the key recommendations in pregnancy is that aim at a blood pressure which is less than 140/90. If the patient has got severe hypertension more than 160/110, you need hospital treatment as an emergency. We know the first line drugs are labetalol, methyl dopa, metoprolol, and dihydropyridine calcium blockers like nifedipine. Acute severe hypertension, one has to be active, give intravenous labetalol, urapidil, nicardipine, or oral short-acting nifedipine. Preeclampsia prevention, aspirin is recommended for that in women at moderate or high risk between weeks 12 to 36. This is one of the important class 1 indication. Thank you very much and for a very patient hearing, and invite questions now.
Thank you so much, Dr. Paul sir and Dr. Andrew sir, for wonderful, excellent presentation. So we have a very engaging audience. We have a couple of questions. So I'll read out the question and I'll put forth the questions to both our esteemed faculty. So the first question is from Dr. Premji, who asks, Indians tend to have atherogenic dyslipidemia, high LDL, low HDL, and high triglyceride. Recent recommendations no longer include HDL as a CV risk modifier. So how this will change approach to testing lipid panel? Dr. Kaul, first we take response from you.
See, lipid panel, we should have LDL cholesterol, triglyceride for sure. And in addition, as I told you, once in a lifetime, at least we should have a lipoprotein little a evaluation. And we have the guidelines because LDL cholesterol reduction is very practical. We have the tools for it. And in any situation, keep the LDL cholesterol low, and depending upon the risk, in patients with extremely high risk, we sometimes recommend by the Lipid Association of India, go to LDL cholesterol less than 35 also, as close to zero, I would say, which is not possible, but you can keep it as low as 10 to 20. But in other situations, one has to again, keep it low. In diabetics, we should keep LDL cholesterol less than 70 in any case. And in diabetics with multiple risk factors, again, we should go low. And this is all for primary prevention. Obviously, for secondary prevention, one has to be guiding them to get LDL cholesterol very low. Triglyceride reduction up to 250 to 300 by using specific agents to reduce triglyceride is just cosmetic, because it has not been shown to reduce vascular event. But certainly if it is very high, like 300, 400, 500, then pancreatitis is a problem. And in that situation, fibrates have been useful, which we have. And now that we have newer drugs which reduce triglycerides to very low levels, they reduce the chylomicron levels to significantly low level. So in short, HDL, increasing the HDL, there has been a decade was spent on that, producing certain drugs like dorcitrapib and many other things, which in spite of increasing HDL cholesterol significantly did not work, and some of them increased the mortality because they were producing hypertension. And so that is the reason HDL cholesterol measurement is no longer recommended, because it is no use chasing HDL cholesterol. They're very often associated with high triglycerides, and about triglycerides we already talked about.
Thank you, sir, for that elaborate response. Dr. Ambrosi, sir, would you like to share your viewpoint?
Sure. I'll just say that everything that Dr. Call said was so beautiful. He and I are on the same page. I was just telling my residents the other day that the only LDL goal is an LDL of 0. So I totally agree with him that we should push patients as low as we can. That's really the main focus. HDL and triglycerides, they are markers of elevated risk, but as Dr. Call nicely outlined, they've never really been shown to be mediators of risk, meaning that any pharmacologic intervention that's been developed to bring those down have not been shown to improve clinical outcomes. When I see an HDL that's elevated and triglycerides that are high, yes, I do fibrates. When I think they're at risk for pancreatitis, but for the most part, that's a trigger to me to talk about lifestyle counseling, to talk about diet and exercise and moderating alcohol consumption and some of those things. Those are really the only interventions that bring those things down safely.
Thank you, sir. Next question is from Dr. Vaibhav, who asks, post-coronary reperfusion era, recent studies have re-evaluated role of beta blockers in post-MI. The results have been conflicting. Reboot trial was negative, while beta-me Denblock trial showed lower risk of death and MACE. So what is current stance on beta blockers in post-MI patients without heart failure with reduced ejection fraction, HFrEF? So Dr. Ambrosi, sir, your take on it.
Sure, that's a great question. It's funny that you asked that. I mean, I have my white coat on. I'm in the hospital. I'm on call, and my colleague who just took one of my patients off the table, was asking me that question. We had an RCA STEMI that's been opened up, and the patient has a preserved EF, and he said, "Hey, should I put him on a beta blocker right now?" The trials have been mixed, but I think that the weight of the evidence in an early revascularization era does suggest that beta blockers are not that beneficial in patients that have a preserved EF. So what I'm telling my residents and my fellows that I'm mainly thinking about beta blockers in patients who have had a large anterior event or have a reduced EF. Other than that, if the EF is preserved greater than 50%, what's most important to me is that we get their blood pressure to goal, and whatever gets them to goal is fine by me. And that may not be a beta blocker, like metoprolol, not a very effective antihypertensive. There's a lot of other medications that are more likely to get patients to that 120/80 goal in patients that are being treated for secondary prevention.
Thank you. Dr. Colso?
Well, I would agree completely with Dr. Andrews that beta blockers in patients with normal ejection fraction, the weight of the evidence is that they don't work. There might be, odd situation or some, person with the normal ejection fraction, sinus tachycardia, some ectopic beats coming, you might use it to, specify the patient. But otherwise, in general, other things which are very useful to keep their LDL cholesterol very low, to keep their blood pressure to targets, if they're diabetics, to maintain their, HbA1c around 7 or less than 7 is much more important than, giving them beta blockers.
Thank you, sir. Next question is from Dr. Shah, who asks, in clinical practice, which patient should be subjected to CAC screening, coronary artery calcium screening? Which patient should be subjected to screening with, and which patient should be subjected to screening with CT coronary angio? Dr. Colso. So we would like to take response first.
Well, I think persons who have got a strong family history, who have got multiple risk factors, yet they are asymptomatic. I think calcium screening is a good test, and you can, combine it with the general examination and a echocardiogram to see the LV function and things, because high calcium scores indicate atherosclerosis, and that is the way to go. I won't recommend, totally asymptomatic persons with multiple risk factors to go for a CT angio unless there's an evidence to suggest that that chest pain which he's having, although it looks like a non-anginal pain, and this thing one might get into a CT coronary angio. And that is the way I go about it. And coronary CT angio, unless it is combined with fractional flow reserve measurement, which is coming in a way in Europe, and we still don't have it. has some meaning, but otherwise looking at plaques here and there is going to, confuse the person, and ultimately he shops around and ultimately gets an invasive coronary angiogram and then may sometimes fall in prey for an unjustified angioplasty.
Thank you, sir. Dr. Andrew, sir, your viewpoint?
Yeah, Dr. Call and I are in total alignment on things. So, I would distinguish two types of patients. Somebody that's having exertional chest pain, and for that patient, I think it's very, very reasonable to do a coronary CTA. And in fact, the U.S. and European guidelines would say that for non-invasive evaluation, that they prioritize coronary CTA over other functional testing, which I agree with. It's a real anatomic evaluation. For asymptomatic individuals, CAC scans, I think it's not unreasonable. Usually I'll have a careful shared decision-making discussion with the patient about that, because, the whole idea behind doing that is really to sort of reclassify somebody that, may be intermediate risk to either low or high risk, and to think about initiating them on a statin. So if a patient cares that much about prevention and is asking those types of questions, I sometimes say, well, why do you want to get the CAC scan? Like, if you want to lower your risk, I mean, why don't we talk about your diet, your exercise, whether we might think about starting you on a moderate potency statin, because those testing never reduces somebody's risk. It's really interventions that do that. So, if they're that concerned, we should talk about whether we just want to implement some of those things. Statins have been shown to be beneficial across the risk spectrum, all the way from high to low risk. It's just a question of how much of what your baseline absolute risk is and how much relative risk reduction you get.
Thank you so much for that elaborate answer. Next question is from Dr. Shekhar, who asks, initiating combination therapy with high-intensity statin plus ezetimibe during index hospitalization for ACS has class 2A recommendation in ESC guidelines. And Indian LAI guidelines had also mentioned about early initiation of ezetimibe in hospital post ACS. So what are takeaways for clinicians in India? Dr. Ambrosi, sir, would you like to take this first?
Sure. That's a great question. I'm a big proponent of ezetimibe. I think it has a pretty good safety and tolerability profile. And there is some efficacy when given on top of maximally tolerated statin based on the IMPROVE IT trial. I usually tell patients that it'll take a low potency statin and move it up to a moderate potency, or a moderate potency and move it up to a high potency. So if a patient is willing to do upfront combination therapy, I think that's a very reasonable choice. This may be too much information, but I often look at patients' med lists and see if they also have constipation, because ezetimibe does help with that a little bit as well. So sometimes there's can kind of kill two birds with one stone. But I think it's very reasonable to offer combination therapy to those that are interested.
Dr. Colson, your perspective on this?
This is a situation which we face very often. Patient coming with acute coronary syndrome, and it doesn't know about his lipid levels and everything else. And at that stage, I think hitting the with the agents to reduce the LDL cholesterol markedly, to go as low as possible, is not making any mistake. I think I would rather go with at least a moderate dose of statin with ezetimibe, because as Andrew said, ezetimibe is very well tolerated. It reduces the LDL cholesterol further by about 20%, and do it maybe 20 milligrams of rosuvastatin along with ezetimibe. Or, if the person is young, has come with a second myocardial infarction, I would go full blaze and sometimes give all the three agents also. Ezetimibe, bempedoic acid, and moderate to high dose of statin. Because as we've been repeatedly emphasizing, that LDL cholesterol, keeping it very, very low, is extremely useful in all category of cardiovascular disease patient, coronary artery disease patient. And a patient who comes with acute coronary syndrome, and you still don't know what is his coronary anatomy like, before embarking on convincing the patient, he may agree or may not agree. Especially in our situation, very often they don't agree for days together. So at least bring down the LDL cholesterol levels as fast as possible by using combinations. Yeah.
Thank you so much, sir. Next question is from Dr. Anil, who asks, like you rightfully mentioned in your talk, Indians tend to have high LP little a levels. So in the current scenario, where we still do not have any available medications for LP little a, what are the upcoming therapies? And in the absence of any agent currently, what should be our strategy for this patients in mainstream practice? Dr. Paul.
Well, LP little a in Indian population is in general higher than the Caucasians in Western population. That is very well known. And about 20 or 15 years ago, we used to think that niacin is going to play wonders and other thing, and very often in small, reducing it at the same time, also reducing the triglyceride levels, and at the same time increasing the HDL levels, which was, thought to be wonderful at that time. But then came a number of trials showing it doesn't mean anything. It has come again into attention that we know that high lipoprotein little a levels make you prone for events, coronary artery disease, obstructive coronary artery disease. And not only that, also in elderly people, aortic stenosis, they also, have more aortic stenosis. So in that situation, and we know a lot of work is going on, and at least 2 or 3 agents are in the phase 3 these days. And preliminary results seem to be very encouraging. And I think it's a matter of time. We're going to get an agent which is going to be, because what we are interested is not only reducing the LP little a levels, but also improved outcomes. So one has to see, we now have agents which reduce it, and they're not harming. At the same time, we need to be a little patient and wait for the outcome trials.
Thank you, sir. Dr. Ambrosi, sir, your take on this?
Yeah, LP little a is an interesting, non-traditional risk factor because it's genetically mediated and it's fairly unresponsive to all of the currently available pharmacologic and non-pharmacologic therapies. It doesn't respond to diet and exercise, doesn't respond to statins, maybe a very small amount with a PCSK9 inhibitor. There, as Dr. Call mentioned, the Horizon and Acclaim LP little a trials are going to be finishing up in the next year or two. So we should have some data on whether LP little a lowering drugs, whether the reduction that we see in LP little a in phase 2 studies correlates to clinical outcomes in phase 3. So very excited to see about that. But until then, not too much in terms of treatment options. The one thing I'll say is that people often, just because these other beneficial interventions don't lower LP little a, doesn't mean that we shouldn't reinforce diet, exercise, statin, and other available therapies in patients with elevated LP little a. It may not reduce their LP little a, but it will reduce their overall risk profile.
Thanks. Right, sir. Thank you. The next question is from Dr. Shankar, who asks, ticagrelor and prasugrel, both are potent P2Y12 inhibitor. So how to choose, what are the patient subsets to choose either? Dr. Ambrosi, sir, over to you.
Sure, that's a great question. Yeah, I didn't talk too much about prasugrel in my talk today. That's also a next generation potent P2Y12 inhibitor. I personally don't use a lot of prasugrel in my patients. If you look at the trial results for it, they weren't quite as impressive. The reduction in ischemic events was pretty much offset by an increase in bleeding events. So I tend to believe that it may be a little bit too much of a good thing, and that patients don't tolerate it quite as well. There were even some safety signals in some select populations. Older adults, as well as patients with a prior ischemic strokes, may have had even more issues with bleeding. Most of my practice is actually restricted to clopidogrel and ticagrelor, and I tend to use ticagrelor in younger patients who I think can tolerate a more potent P2Y12. So that's been my practice. But interested to hear what Dr. Call does.
A very interesting question. And in fact, we just finished a trial, which is going to be a late-breaking trial at the American Heart this time, so I can't talk about that. But prasugrel has been available with us. And one of the studies from the German investigators from Munich last year, I think 2000, about 5 years ago, the ESA-REACT study in acute coronary syndrome compared ticagrelor with prasugrel and came out with the result, a startling result that prasugrel reduced all the events more than ticagrelor without any increase in the bleeding. So that is the trial. And then there is, sweetheart studies and others showed that they are equivalent. They do not increase the bleeding that much because prasugrel became kind of a drug which became known for more bleeding when the Triton came because they had included everything. We now know that what are the high risk patients who get bleeding with prasugrel: lean and thin people, people who have had a history of ischemic stroke, and that kind of people. If you are careful, this is a very useful drug, and the advantages are that it is once a day. It does not produce dyspnea, as Andrew was mentioning, between clopidogrel and ticagrelor in one of the papers from, I think that was from Kuwait Hospital in Pakistan. So this is a coming up drug again, and as I told you that we just finished a study and we have got some very interesting results. We started as a non-inferiority study, but we got some very interesting features. I think you could get some hints out of it.
Thank you, sir, for sharing that. Next question is from Dr. Satish, who asks, post-ablation for atrial fibrillation, can oral anticoagulants be stopped? If not, how long to continue? Dr. Satish, Dr. Colson.
I think atrial fibrillation, whether it is paroxysmal, whether it is permanent, whether it comes once in a blue moon, if the shared score has been more than 1, you have to continue it. After RF ablation, obviously you have to continue it. And we also know that the success rates of curing in RF ablation for atrial fibrillation are not, fantastic. If you get 40%, 50% success, also you're lucky. So I think there is no place for stopping oral anticoagulants in this situation. And if you cannot use for some reason, then I think left atrial appendage closure is the way to go about it, because stroke is a devastating problem and you can't play with it.
Thank you, sir. Dr. Ambrosius, your viewpoint of this.
Yeah, I have to agree with Dr. Call. I think regardless of CHA2DS2-VASc score, after an ablation, patients need to be on oral anticoagulation for a period of time, just like after a cardioversion, because there's some atrial stunning and they're acutely at higher risk of stroke. Long-term need to use CHA2DS2-VASc, and the majority of patients are going to have an elevated CHA2DS2-VASc and need to continue. The data correlating the burden of AFib with the risk of stroke is not great, and there's a lot of folks out there that think that atrial fibrillation is just a marker of atrial myopathy that leads to increased stroke risk. So I would say just because the AFib has gone away following the ablation, people should not be reassured that lowers the risk of stroke, and that's really where oral anticoagulation comes in.
Yes, sir. Thank you. Now, second last question from Dr. Anand, who asks, for heart failure, GDMT for heart failure has changed patient care. So what is the current status of digoxin, and which patient subgroups can still benefit? Dr. Ambrosius, over to you.
Yeah, that's a great question. This is a very well-read audience. So folks probably know that the DIGIT-HF trial just came out at ESC, which was with digitoxin, another cardiac glycoside, and they took patients, contemporary HFrEF patients that were on good background GDMT, and met their primary endpoint, showed a reduction in all-cause death and hospitalization for heart failure. And this is after digoxin use has fallen off over the past few decades. I'm very intrigued by these results, and I think that I'm not sure if digitoxin is available in India. If it is, I think that those results are directly applicable, and something that people should consider. Digitoxin and digoxin are not the same. Digitoxin is more lipophilic and it's not renally cleared, so it has much more stable levels. So I don't know that we can extend the evidence from digitoxin to digoxin. There is a trial coming out at AHA called Decision that's going to be looking at digoxin, so there's more to follow. But I think if digitoxin is available in India, that is a very reasonable choice in patients that are on triple or quad therapy and continue to be at risk for hospitalization.
Dr. Consa?
Well, digitoxin is not available in India, and you can't, get the results of digitoxin and use digoxin for that. That's for sure. So, digoxin we use in heart failure, especially in patients with atrial fibrillation, which is a common arrhythmia, to control the heart rate in modest doses. To that, it's fine. Some people have started using it in patients who cannot, get optimal doses of RNA for some reasons. This sacubitril valsartan combination and the other drugs are there, and patient is not improving as a kind of a last ditch effort. You start using digoxin, but then the data is not very strong regarding that. And at best, also the digital trial had shown that it reduces the hospitalization rates, and it never had shown that mortality reduction was there. So I think the role of digoxin, which is available here in patients with heart failure, is not very convincing that it should be used, except in certain, situations where you have no other choice, or atrial fibrillation with fast rate not coming under control with beta blockers and other things.
Thank you, sir. Last question from Dr. Bhatt, who asks about mental health. Addressing mental health condition is challenging considering overall awareness and stigma amongst population. So guidelines emphasizes considering mental health risk in CVD and vice versa. So what key takeaways can cardiologists add in practice for optimal patient outcomes? Dr. Kalsa.
I think mental health, as I was discussing, is a very important part of the complete holistic management. We every day see depression, anxiety in these patients, and very often in our busy day-to-day practice, ignore that and then tell them, okay, go and take a tablet of Valium or something at night. But that's not the way it has to be treated. It has to be taken seriously now that we know. In fact, even in the HOPE study, it was very clear that out of one of the 9 risk factors, depression, and was one of the very important risk factors. Psychosocial problems was one of the very important risk factors. But handling that has not become a practice. But the guidelines very clearly suggest that they should be looked for. People who do not have heart disease yet have a lot of problems of depression, anxiety, are more prone to get heart disease. So they should be looked after as far as their mental health is concerned, and not only to make them, feel fitter, but also to prevent some of the vascular event. But patients after myocardial infarction, acute coronary syndrome, heart failure, pulmonary hypertension, they all have got varying degrees of depressive and anxiety levels, as I showed. And all of them, it's always good to take notice of it, have a team member in your cardiovascular team who has a fair knowledge of it. Could be a person from the psychiatry department, and involve them and in the management of that. Patients very often, do not come out with this particular symptom, but you can see the families tell us that, they spend sleepless nights, they're not sleeping, taking pill after pill. That is not the way to go about it. I think counseling as well as the good medication is very, very important. I think what and very.
Dr. Andrews, sir?
Yeah, I agree completely. I think it's in most instances it's safe to treat mental health issues. Most SSRIs and many other drugs have been shown to be safe from a cardiovascular perspective, and I think that the reason that depression shakes out as being an important risk factor for patients with risk factors or established cardiovascular disease is probably because when people are depressed or anxious, they're not taking good care of themselves. They don't have a great diet. They're not exercising. They may not be as adherent to their medications. So, it's really important that we not narrowly focus in on cardiovascular disease and that we take a holistic approach and treat the whole patient.
Thank you so much. And with this, we come to end of the Q&A session and our program. So we are deeply thankful and we are honored to have both of you, both our esteemed faculty, Dr. Upendra Kaur sir and Dr. Andrew Ambrosi sir with us. And we are happy to share that we have over 2,000 audience, doctors who have joined in for this. And it's a Saturday evening. And so we are very sure that from this discussion, from this talk, the clinicians would have greatly benefited, and ultimately it will help in improving the patient outcomes. So thank you, sir. And thank you, dear doctors, audience who have joined us. And last but not the least, we also thank our technology partner, DocMode, for smoothly streaming this session. So thank you all and a very good night.
Thank you.
Great.
Thank you very
Thank you so much.
Thank you.
Bye-bye.
Bye-bye.